about hip width apart, toes pointed forward, feet parallel. Good. Then you're just going to come and take a look at the arches under both of his feet. So you'll just run your hand. You can even first of all just take a look on the inner side of his foot. And if you look just underneath the medial malleolus at the bony part right here, take a look for any bulging on the medial malleolus. Yeah, so if you just stand normally, you can see here how he just moved his foot. His foot went in a little bit. How all the bones move more medially, so you've got like a bulge underneath the medial malleolus. And forward. You can see it better when you're directly in line with the person, directly in front, but you can see that his foot, as it medially rotates, there's a bulge underneath the medial malleolus, indicating his foot's pronating. And you can also check by just running your fingers underneath, I'll try not to tickle you, underneath the arch of his foot, and then you can tell if there's any difference between the arch collapsing on the left or the right foot. Some people, the guy that was here on the Monday lab, the gap between the foot and the floor on, I guess, left or right foot was bigger than that on the right. So, and one of his feet was pronating more than the other. And then that bulge underneath the medial malleolus was then again the foot that pronated more. There was more collapse of the bones on the side that was pronating more. So it's one thing to take a look for, and yeah, he doesn't have a very big space between his arch and the floor, so yes, he definitely does pronate. So whether this is structural or functional, you guys talked about, yeah. So structural meaning that you've got no or have no arch in your foot, whether you're unweighted or standing. If it's functional, it means you've got a bit of an arch when you're unweighted, and then as soon as you step down, that arch just collapses. So to differentiate between the two, if you turn around so your back's facing everyone, you can take a look at the heel cord, basically the Achilles tendon. And if the individual's feet, no arches, totally flat, but their heel cord's nice and straight, it's probably structural. But if their heel cord has a bit of a bend in it, like his, you can see straight would be right down like, straight would be right down, but his heel cord's angled a little bit. So he's got functional pes planus, so functional flat feet. So if you flip around again. Generally, if someone has structural pes planus, it's okay. Anatomically, usually they're asymptomatic. If it's functional like this, they can, and if it is symptomatic, they can be referred for orthotics. If it's a cavus foot, so if it's a high arch, there's generally not as many problems, but they can get some tightness of the heel cord due to that high arch and some Achilles tendonitis, but generally speaking, there's more problems with the functional flat feet than the cavus foot. So if we take a look at the feet, we work our way up. Next, we can take a look at the tibia. So there's something called tibial recurvatum, and if I show you on the skeletons, now in the normal individual, if this is your tibia, the shaft of the tibia, this front bone right here, is just nice and straight. What that means is if you've got your nice straight tibia, it's coming down. I'll show you on my foot here. So this is my tibia, and this is my, if I come down from my foot, it's at a nice 90-degree angle here from my foot up to the tibia. So this angle coming out of my foot is at a nice 90 degrees. If someone has tibial recurvatum, so this tibia here, if you take a look, it might be a little hard to see, you might have to come up and see after. But this one's nice and straight. This tibia, I'm going to exaggerate, but the front bone is kind of bowed outwards and then comes down. So what happens now is the foot wants to be at a 90-degree angle to the tibia, but instead, because the tibia is bowed outwards, so in order to get that nice 90-degree angle between the foot and the tibia, the foot pronates inward. So now, when it's pronating inward, it's at a 90-degree angle from the foot and tibia. So if you take a look at the shaft of his tibia, now I'm standing beside so I can't really see, but does it look like the tibia is running straight, or does it look like there's any curvature of his tibia? When you are checking, one thing you have to be aware of is the musculature. Sometimes if people have musculature on the lateral sides, it can look like the tibia is curved, but take a look at just the actual bone of his tibia and see if you can notice anything. And what I'm going to do at the same time, if you take a look at my tibia, see if you notice anything different between the two of us.
I'd say yes and no.
Yeah, so if you see my tibia, they're kind of curved out, whereas his, from my angle, if I run my finger, they seem to be pretty straight. So his are fine, mine do curve out, and at the same time I do have pes plana, so this isn't normally standing. This is, if you take a look at my heel towards the back, they're bent outwards. This would be me ideally standing if I had arches. So pronating, ideally standing. So I do have the tibial recurvatum. So if we move up from the tibia, actually if you roll those up again, now we'll take a look at the patella. Ideally, your patella, your kneecap, will be both the same height and they'll be facing forward. So if you had, pretend instead of patella you had two flashlights shining from either patella. If you take a look at his, would those lights be both pointing forwards, or would one be pointing to the side, pointing inward? From where you guys are standing, do his patella look like they're pointing straight forward or a little bit tilted from side to side? But sometimes it helps. So now, might be hard to see from back there, but if I put my fingers on the medial and lateral edge of his, what's this, your left foot, left patella, this one here, if I put a flashlight on it, it's going to be shining out that way, when ideally it'd be shining straight forward. And this patella here, just relax your leg. Here, same thing. So I'd say they're both kind of pointing outwards if you had flashlights on either one of them. So they're sitting a bit laterally. So if I'm to exaggerate it for you guys, if I put my hand directly on top of his patella, my hand's pointing laterally, whereas it would be ideally just straight forward. And the same with this one here, hand on either edge, it's positioned laterally and ideally it'd be straight forward. Do you get any knee pain?
No.
No? Well, you're lucky. It could be due to either a tight IT band pulling the patella over, or it could be due to, although it looks like you've got a pretty good
the side I'm actually injured on, so I don't know.
Yeah.
Knees are fine though.
So it could be due to a tight IT band, just his anatomy, but if he has no pain, then great for him. With my knees, you might not be able to notice, but on my right side, my right patella sits a little bit more laterally than my left. So the lateral angle of my right patella, or lateral edge, sits closer to my femoral condyles. So when the lateral side rubs a little bit more, so you can, might be hard to see, but if I put my hand on it, my patella is sitting back a little bit more, posterior on the lateral side. So it gets some rubbing. So it's something to take a look for. Come up to the patella, put your hand on either border, front to back. Okay, are they sitting nice and straight? Are they looking left or right, or nice straight forward? It could be due to a tight IT band or just insufficient strength of the vastus medialis muscle, which would keep that patella tracking.
What would you call this? Patellar?
The position of the patella?
Yeah, is there like one of these?
Oh,
is it on
no,
the list,
I'll
or
kind
is
of
just...
go through them at the end.
Okay.
Right now, I mean, in terms of the patella, you've got patellar crepitus, which is basically just kind of like a grinding noise within the knee. So if you put your hand on your knee and bend back and forth, sometimes people feel kind of like grinding sounds within their knee. Patella alta would be something you could take a look for. Normally the patella is sitting nicely in the groove of the femur. Some people's patellas are positioned up higher, and there's one guy, no, he's not in this section, but he has patella alta, so his patella is sitting like way above his femoral condyles. So when you go and palpate his knee, you can feel like his entire femoral condyles, and his patella is sitting way on top of it. And yeah, patellar subluxation can be an issue if your patellas are sitting a little bit laterally. If you've got a tight IT band, you can pull that patella right out of the femoral condyles. And then if it's subluxed, it'll pull laterally and just move right back into place. But if it's fully dislocated, it'll pop out and stay out. So if we work our way up, his tibias are fine, they're pretty straight. He's got some pes planus. Patellas are angled a little bit laterally. Next thing you can take a look for in terms of knee pain is at the pelvis. If he has pelvic obliquity. So have you guys discussed this in class yet? No. So pelvic obliquity just meaning the pelvis isn't exactly level. So it can be either that there's a muscle spasm in the back, which is causing one side of the pelvis to be hiked up. It can be a leg length discrepancy. So if I've got one leg longer than the other, my pelvis is going to be tilted. Or it can actually be the hemispheres. So if you've got, this is the pelvis here. Turn mine around. You've got the left and the right side. One of these hemispheres can actually shift. So you can have one hemisphere rotated forward or backwards in relation to the other one. So what you can do to check for pelvic obliquity, I'll just come behind you. You can face them. Oh, the other way, sorry.
This way?
Go full circle. Yeah, there we go. So you just come behind, just find their pelvis, so on top of the iliac crest, and see if they feel, I'm just kind of eyeballing it right now, do they feel pretty much the same height? Yeah, I don't notice anything super out of line with his, so that's okay. If they were out of whack, one thing you can do is get them to just sit on a hard surface, if you just sat on a table.
This way?
Yep. And then you could again, measure the pelvis. Are they the same height or not? So if they were uneven when he was standing, get him down to sitting, now they're the same height. It could be due to a leg length difference. So now you've just taken the legs out of the equation. If they were still off, next thing you could do would be to measure his leg length. So I know this table's kind of short, but if you could just lie back on the table. So really, and sorry, I can come to it. If you want to get a true leg length measurement, you would actually have to get an X-ray so they could tell the length of the femur and the tibia. But you can just get a bit of an approximation with using a tape measure. So if you just have both legs. Okay, so yeah, I'll just kind of shift you there. Sorry, these tables are not that great. There's a class on the other side, so I kind of make it work. So you can get what's called an apparent leg length if you hold the end of this and just keep it on your belly button.
Oh.
Your head of me. And it's apparent because you're starting from one central location, the belly button, and then you're coming down, marking at a common spot on either leg. So I'm going to use his medial malleoli, and I come from his right, about 29, go to the left, about 29. So they seem to be pretty similar. And now you were ahead, so if you put it on the ASIS, so right at the front. There yeah. And then come straight down, malleoli, about 26 and a half, and then go to the other side. And got it on there. So, this one seems to be a little bit shorter, but that being said, I mean, this is still a ballpark. So the first one, measuring at the navel, is called the apparent leg length. Measuring at the ASIS is called the real leg length, but to get a true leg length, you have to get an x-ray. So, I mean, this is useful for, you know, big differences, but if it was something subtle, you really want to get an x-ray done. Especially because if you do have any kind of rotation at the pelvis, so if your pelvis is rotated, it'll seem like there's a leg length difference, but really there isn't. It's just that the pelvis is rotated, so when you do that measurement, the leg length is the same, it's just because the pelvis is throwing it off. Another thing you can measure is something called the Q angle. So, I think you guys have discussed this in class. Q angles? Yeah. So it's just the measurement in the hips in relation to the knees. So women generally, wider hips, have a larger Q angle. Men generally, with smaller hips, have a smaller Q angle. What happens if you have the larger the Q angle is, the greater the chance of problems, especially at the knee. So to measure the Q angle, if you just lay back again, and what you can do is you want to find the center of the patella, and again, just like measuring leg lengths, this, you know, it's high to error. I'm landmarking on his body, trying to find the center of the patella, so really you'd want to do this a few times over and then kind of take an average. It's not exact by any means, but it's an approximation. So to find the center of his patella, just kind of squish on either, or press on either side, front to back, side to side of the patella. If you make little white marks on the skin, you can kind of see where the center of his patella would be. And as you can see, he's already highly susceptible to error, but do your best. Put a little mark in the center of the patella. Then, if you get him, or subject, patient, whatever, hold on to the tape from the top of the ASIS. I'm going to run it right down through my center mark, and I'm going to draw a line. So this is the angle we got from the hips to the knee. Just draw kind of a big line down. Sorry if I'm drawing one you didn't ask. Then you're going to do the same thing from that center point in the patella down to the top of the tibial tubercle. So center of the patella down to the tibial tubercle. Draw another line. So if you just kind of rotate so they can see your leg. So you've got center of the patella. This line here I've drawn down from the ASIS to the center of the patella. I just continue the line down. And then I've got another line from the center of the patella down to the tibial tubercle. Then I'm going to put my goniometer in the middle of that center mark, and I'm just measuring the angle of those two lines. So with him, we've got about 9 degrees. So for a guy, that's totally fine. I'm going to double check on this so I don't play the wrong thing, but in terms of Q angles for a man, anything generally less than 12 degrees is fine. For a woman, you start to have problems up above 20 degrees. So, I mean, he's totally fine in terms of his Q angle. So that's kind of what you do in terms of biomechanical analysis. So you'd start at the feet, taking a look at the arches, the tibia, tibial recurvatum, the patella, then come up, okay, the hips, are they level, upright or not, leg lengths, Q angles, that's kind of where we're at. Another thing you can take a look for on an athlete is, it's on your handout called femoral retroversion and anteversion. So here are two femurs. And sorry, I'll get you to stay here because I'm going to use you in a minute. But this femur has anteversion. What it means is that the femur, if I was to insert this into my leg, if you take a look at the femoral condyles at the front here, see how they're pointed medially or rotated inwards? So if this, I've got, femur inserted into my hip. This anteversion, the femur is rotated internally, which means the entire leg then is going to be rotated internally. So some individuals with their toe inward when they walk could be due to femoral anteversion, rotating inward, whereas femoral retroversion is the exact opposite. So now this is my femur. If you take a look at the bottom, femoral condyles now they're pointed outwards. So if this is my leg, I'd be out, kind of duck leg. So if you get your partner to just lie down on the table, just nice and relaxed, sure, yeah, it doesn't matter. And then it's going to be, well, it works. So just nice and relaxed. Generally speaking, everyone has a little bit of retroversion, so normal, again, would be with both feet to be outwards a little bit, just a little bit like that. So now you just stay nice and relaxed again. Just kind of shake your legs out, I think, because that was good. So his right foot has I'd say that's pretty well normal retroversion. His left foot has got a little bit of anteversion, so they're not exactly the same. His left foot comes a little bit in compared to his right. So it's just something to take a look at with your partner. Everybody's different. There's someone in the last class had like pretty major anteversion. Some people have quite a bit of retroversion. A lot of times ballet dancers will have retroversion. It's not that ballet created the retroversion, it's just that if their legs naturally are like this, they're going to be better dancers due to the position of ballet. So can help you in some sports or activities. So that's femoral retroversion and anteversion. And I'll kind of go through most of this stuff, like we've talked about valgus, varus, pelvic obliquity being either muscle spasms, leg length, or pelvic hemisphere shifts. Patellar crepitus is just the noise in the knee. Alta, patella's up high. So chondromalacia, that's just the subpatellar pain. So any pain behind the kneecap. IT band syndrome, we've discussed a little bit when we were going over the knee anatomy. So if you remember, the IT band starts up at the TFL, tensor fasciae latae, comes down inserting onto gerties. So when you're in flexion and extension, that IT band crosses over the lateral femoral epicondyle. So if people have tight IT bands, especially like sprinters where they're crouched and they have that constant flexion and extension, that IT band can rub back and forth every time you're flexing and extending across that lateral femoral epicondyle and can get irritated. So that's the IT band syndrome. Anterior compartment syndrome. Have you guys discussed this in class? Yeah, so tibial stress syndrome, just a fancy name for shin splints. And yeah, we'll just kind of get right into part 2 about hamstring strains. Again, that stuff that you guys will just, you'll cover that more in lecture. So if we jump into the palpations, you guys are lucky, there's only a few palpations for this lab, so if you want to stand up. Some of which are not examinable for what will be obvious reasons. But if we start off, the first one we have is the ASIS, so your anterior superior iliac spine. So if you take a look on the mannequin, it's the bony protuberance at the front. Generally speaking, it's where your pants are sitting. So if you come up to your subject, and I'll just come behind you, just find the hips or top of the iliac crest, come forward, and you can feel the 2 bumps on either side. That's the ASIS. Pretty easy to landmark. The The inferior iliac spine, so the one just below, isn't really palpable or examinable because you've just got a lot of tissue over top of it. You can't really feel it. The next two, the ischial tuberosity and pubic symphysis, are not examinable.
That's good.
Yeah.
I was just trying to find it there.
So ischial tuberosity, basically right underneath the fold of your buttocks. Pubic symphysis is where the two hemispheres join in the front. So you don't need to find those on us. Please don't. The next one, greater trochanter. So essentially just the top of the femur, greater trochanter, the bone sticking out the side. To feel this one, just get the individual to stick their hip out to the side. So if you just stick your hip out, yep, and there you go. You can just rub along the side of the leg, and that's the greater trochanter. Another thing you can do, you can have them stick their hip out to the side, or you can get them to just lie down on a table. So if they're lying down nice and flat, all the musculature is relaxed, and then you can palpate it that way as well. But I think for most people this is pretty easy. Just make sure you're down low enough. Some people, they're kind of way up here at the hip, but remember this is the iliac crest. Your femur is actually quite a bit lower down. So just make sure that you're down lower. So this is my iliac crest. My greater trochanter is actually way down here. So there's two left, SI joints and spinous processes. So SI joints, just at the back, this guy turns around. So you've just got the joint, the sacrum and the ilium here. So generally speaking, you can feel these two bony protruberances in your lower back. And then if you come down off those, and if you just feel side to side, you should feel kind of bone dip bone. So it'll be bone dip bone, it's this joint there. It forms a bit of a V, so wider at the top. And then as you get farther down, it kind of narrows down. So you can find those. Got those, yep, so on the lower back, and then down. And then the spinous processes just come to the middle of that triangle, and it's basically all the little bumps along the top. So you can feel those on yourself. All right. So those are the only ones that are examinable. The ASIS, greater trochanters, SI joints, and spinous processes. Ischial tuberosity and pubic symphysis, put a little X beside, they're not examinable. And that's it. Oh, in terms of lower back problems, we've got here William flexion X's and McKenzie extension X's. So those are just a bunch of exercises that have been developed by those, Dr. William, Dr. McKenzie, by those individuals just for people with lower back pain to kind of take the stress off the lower back. I've got a list of them. If you're interested, I can kind of show you them. But yeah, so that's pretty much it for today. I've got, so we've still about 15-ish minutes-ish till Dave comes. So the goniometers and tape are there. I'll bring them over to the other side. You guys can measure leg lengths, Q angles,